Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. November is Diabetes Awareness Month. According to the American Diabetes Association, more than 154,000 people with diabetes in the U.S. undergo amputation each year. But with early intervention and expert care, many of those limbs can be saved. That's why today we're talking about limb preservation with Dr. Samantha Minc, a vascular surgeon at the WVU Heart Vascular Institute. Welcome, Dr. Minc, to Tuesday Talks.
Thank you so much for having me.
It's great to have you here. So let's talk a little bit about West Virginia. It's estimated that more than 1 in 10 West Virginia adults have diabetes, meaning West Virginia has the second highest rate of diabetes in the country. So why are people with diabetes at risk for amputations?
So that's a great question. So diabetes, it's interesting the way that it affects your blood vessels. And I just want to make it clear from the onset that diabetes does not mean that you need to lose a leg. My grandmother is 104. She's a type 1 diabetic, and she has never had any issues with her legs. My mother is in her 70s. She's a type 1 diabetic, again, doing fine. And really,
that's great.
Absolutely, and I know we're lucky for sure. But a lot of this is taking care of your diabetes and managing it so that you don't end up with the complications of diabetes. So somebody that is taking care of their sugars and has access to be able to do that, those people are much less likely to have those kind of complications. Now, in people that are not able to take care of themselves and take care of their sugar, basically what happens is that having all that sugar floating around in your bloodstream is not good for the small blood vessels. So just think of it like big clunky things that are just bouncing around in there and causing damage specifically to the small blood vessels that go to the eyes, go to the kidneys, and go to the feet. So these are all part of the same system. And so that's why when you start to lose the blood flow to the feet, that's where you start having your risk for amputation.
Oh, okay. Well, that makes sense. That makes sense. Now, I also know that peripheral artery disease, or PAD, is also a big cause of potential limb loss. So what is peripheral artery disease and how does it lead to limb loss?
Sure, and so again, this all comes down to blood vessels. So people with PAD have disease in the arteries that go to the legs and to the feet. And the same thing again, so this theme of people with diabetes, it's just that diabetes aggressively damages arteries when it's not controlled. So it's all part of the same picture. And that can be a little bit confusing where you're like, well, do I have vascular disease? Do I have diabetes? A lot of the time, these are very closely linked together. However, there's also a whole group of people that have problems with blood flow, mainly because of uncontrolled blood pressure, cholesterol, and smoking. Smoking is our number one cause of peripheral artery disease. In fact, people that have smoked more than 100 cigarettes in their lifetime, half of those people will have some kind of damage to their arteries.
Oh, wow.
I know. It's a crazy number.
Yeah.
Most of that is people don't even know. But a small percentage of those people will end up noticing symptoms of PAD.
Which would be, what kind of symptoms?
So basically pain in your legs when you walk can be a big one.
Okay.
So if you think about it, like if you go to the gym and you're running on a treadmill or something and you get a cramp in your leg, so that's how these folks feel, just kind of like walking normally or even just sitting when it's very severe. Ooh. So the legs are screaming for blood and so the muscles are cramping because they're unhappy.
Okay.
And yeah, so that is one of the big symptoms. The other thing that you'll see when you don't have good blood flow, and this is where we start getting onto this like what we call like a stairway to amputation, is developing wounds because there's just not enough blood flow to keep the skin healthy. And so if you get a cut on your foot, then it doesn't heal, it gets infected, and then you're at the risk for amputation. This is probably also a good time to talk about, again, why diabetes is so closely associated with it. Because the other damage that diabetes does is to the nerves in the legs. And this is also, again, it's the blood flow to the nerves that kills those nerves. But you suddenly lose the ability to feel the bottom of the feet in a normal way. And so there's a couple things, again, that happens here that people that you may walk, you may step on a thumbtack or something and not know it's there
And
for a
not
couple
even
days.
feel it. Wow.
Yes, and so there's that. There's also normally when people walk, if they don't have neuropathy, your feet are constantly making changes as you're walking. So your muscles in your feet are always moving, shifting, so you're not putting the same pressure every single step.
Okay.
If you have neuropathy, your feet can't do that. And so you're almost like wearing out the bottom of your foot, so where the bones press.
Yeah.
And so what you'll see is deformities in the feet, the change of the foot kind of just changes because the muscles kind of weaken also because of blood flow, plus the neuropathy, plus the pressure points. And so you kind of like just wear kind of a hole on the bottom of the foot, and that's a very classic diabetic foot ulcer that people can get. And if they don't check their feet regularly or they can't feel that ulcer, then it's more likely to get infected. Exactly. And then you have these big sugar molecules floating around making your white blood cells that help take care of infection. They can't do their jobs. And so then the infection spreads quickly. And so all of these things come together. It's kind of like the perfecta.
Yeah.
And then if you add artery not flowing well, that's where you really run into the highest risk of amputation, is this combination of out of control diabetes plus the arteries not being able to do their jobs. Because if you have good blood flow, a lot of these things can just heal.
Right,
but if you don't, that's where you run into trouble.
So that's the bad news. Let's talk about the good news solution.
Absolutely.
Limb preservation. What is limb preservation?
So I would almost say that limb preservation, we've already gone too far when we're talking about limb preservation, because that's when you have diabetes, artery disease, and wounds that we're trying to heal.
Okay.
85% of all amputations due to diabetes are preceded by a foot ulcer. So 85% of these have had a foot wound that just wasn't taken care of in a timely fashion.
Okay.
So getting access to a foot doctor, a podiatrist, early, and being screened early by primary care doctors, they're supposed to be looking at your feet at least once a year. If you're high risk, if you have neuropathy, they should be looking at it every 3 months, and they should be sending you to a foot doctor.
Yeah.
And that way they can look and they can make sure that things are okay, and maybe they'll give you a special shoe or do some sort of work to make sure that that's all right. And they may also be the ones trimming your toenails, because you don't want to risk cutting your toe like while you're doing your nails. So there's all these these things that can be done. So we know that about 85% of these are preventable.
Okay.
And they can be prevented by having access to a good foot doctor, podiatrist. And if it comes to it, if the foot doctor's like, you have this wound, it's not really healing well, and I can't feel a good pulse in your foot, we need to get you hooked up with a vascular surgeon. And so we have a very close relationship. We call it the toe and flow partnership.
Toe and flow.
Yeah. So I'm the plumber.
Okay.
And these guys are the construction guys.
All right, that makes sense.
Yeah, and they make sure that the house is able to stand, so the foot architecture is properly taken care of, and I get the blood flow to the foot so that whatever they're doing can heal. And so we know that early prevention with just primary care doctors doing regular foot exams and identifying and risk stratifying, so if they see that you have neuropathy, that you see you have these problems, sending you to the proper people, having that information though to do that. So they risk stratify it, they can look at this data, they could say, all right, according to this, you are risk level 2. You need to see a foot doctor every 3 months and come back.
Okay.
All right, so if they can do that, again, up to 85% amputation reduction.
Wow.
Absolutely. We also
Just
know.
by going to the doctor.
Yes. Well, not just going to the doctor.
Not just going, but you
making sure
being
that the
aware.
doctors. Yes, but making sure that the doctors also have the tools to do what they need to do,
Yeah,
right?
yeah.
Because we tell people, oh, just do foot exam, check it off, right? That's not the same as really having your primary care doctors learning that this is important, doing the exam properly, and doing that risk stratification. So that's kind of more of a new concept, that not only do I need to know how to look for it, but I need to know what to do if I find something abnormal.
Okay. So where does your part come in then as a vascular surgeon? I mean, does it often come to surgery to preserve a limb?
So that is, like I said, it shouldn't come to me, but yes. When we talk limb preservation, oftentimes we're talking about there's been a wound, it's not healing, now we have to do things to try to take care of it and preserve it. And so as a vascular surgeon, often it's my podiatry colleagues. In the best case scenario, it's one of my foot doctor colleagues, and they are taking care of a patient that has a wound that's not healing right, and they are like, this doesn't look right, I'm going to get a test, going to see it, oh, blood flow is not great. They come see me in clinic, I get them hooked up, and I take them and I do an angiogram to take a picture and maybe do a balloon, something non-invasive, to try to open up the blood flow to get that foot healed. There are times
when you're talking about do a balloon, can you explain that? Do you do that on the foot, or, you said it's non-invasive.
Right. So, and non-invasive by surgery standards, of course. Yes. But the same thing, a lot of people may be familiar with doing, people having heart catheterizations.
Yes.
So same concept, we go in through the artery in the groin, and then we kind of follow the roadmap. We go up, usually we go up and over to the other leg, because that's just the best way to do it. And we'll take pictures, so we put we put dye down the leg through a catheter, we're taking pictures looking for narrowing.
Okay.
And then we get a wire across the blockage, and then we get a little balloon to open up, and there's, and it just crushes that plaque, opens it. Sometimes we will do something like a stent if it's a very hard plaque that keeps closing, or if it was a totally blocked artery, sometimes we have to open new passages and we have to open that. Sometimes we use something called a drug-coated balloon, which has special medicine to keep the plaque from coming back. Oh, okay. So we have a whole host of tools that we can use, and we even have some advanced endovascular tools. So endo just means inside the artery.
Okay.
So we can do some complex stuff too, where we're going from different approaches, doing all kinds of things. And then as vascular surgeons, we have the good fortune of saying, all right, this isn't working, but I have other things in my toolkit, and that includes open surgery.
Okay.
And so other specialists don't really have that ability, but that's why vascular, we feel strongly that we are the people to be able to take care of the whole patient when a vascular patient needs something.
Nice.
So I can say, all right, you know what? This artery's, you have a long artery, it's blocked. We're not having a good result opening it, or we can't get across it. So we're going to do a bypass.
Okay.
So again, same thing like a heart
Just with
doctor.
a heart.
Mm-hmm. Yeah. So we may take a piece of vein from the other leg, sometimes from the arm even, and we will connect it from where there's above the blockage to below. So again, plumbers.
Yeah.
We're very fancy plumbers.
Fancy plumbers, I like that.
But we definitely, we have a whole variety of options that we can do. And that's often where it comes to vascular. Unfortunately, a lot of these patients that do end up with amputations are the ones that we meet for the first time in the emergency room.
Oh, wow.
Right.
Where it's
it may be too late for full limb preservation, but we always try to be, minimally invasive when it comes to that kind of stuff. So whatever we can do to try to prevent that limb loss, we will do. But if someone comes in and their toe is totally like gangrenous, so the tissue is totally dead, it's not salvageable, or if it's very infected, then we may have to drain or cut before we would have liked to. And that just depends on the situation.
So what type of signs and symptoms should people look for so it doesn't get to that point with gangrene and you're in the ED and it's too late to really...
So number one is if you have diabetes, you have neuropathy, well, don't go barefoot ever, please. Just please. Stop doing it.
Okay.
My patients I have a lot that are still like, no, this is what I do, and it's not great.
Wow.
So don't go barefoot, always wear shoes and socks. Check your feet twice a day, because you can't always trust the feeling in your feet. So check the bottoms of your feet. If you can't look at the bottom of your foot, have a family member do it.
Okay.
So you're checking for wounds. If you have a wound that isn't healing within 2 weeks, you need to see a doctor.
Okay.
So that's, if we want to talk about what we call kind of tertiary prevention, so end of the line kind of prevention, that's what we're talking about.
Okay. Okay.
If we want to back it up a little bit.
Go ahead, let's back it up.
Yeah. Don't smoke.
Yeah.
Don't smoke. People with diabetes that smoke, it's like putting gasoline on a fire. Smoking tends to attack the arteries that are the larger arteries in the belly and in the thighs. Diabetes tends to attack the smaller arteries below the knee and then the foot. So if you're doing both, you're making our jobs really hard to try to save your leg.
Yeah.
And then people
yeah.
that do continue to smoke, even after we open their arteries, they're 4 times more likely for those arteries to block back up.
Oh, wow.
So that is, one of the biggest messages really is,
Do you have many patients that do that continue to smoke after a procedure like that?
Absolutely. And smoking is
wow.
just one of those things I'm pretty sure the most addictive substance on earth. And it's not the fault of the person that's smoking. This is incredibly addictive. And they really need help to quit.
Yeah.
We know that you're 3 times more likely to be successful if you use nicotine patches or replacement therapy, counseling, and take the medication like Chantix, something like that. Yeah. You're 3 times more likely to be successful. So that's about a 12% success rate. It also takes about 7 times for people to be successful quitting. And so you got to keep at it.
Yeah.
But we unfortunately have patients that have lost both legs and are still smoking.
Oh, wow.
Yeah, and it's not, I am very certain that they're not like, yes, I'm going to keep smoking because I know this is bad for me. I think they're heavily addicted. They're
just
struggling.
Can't help it. Yeah.
And even maybe don't fully believe it. It's hard to say, but yes, smoking is a big part of the job that.
We could prevent a lot of
it would make my life
amputations.
A lot easier. Yeah. It really would.
Yeah, I bet it would.
Absolutely.
We want to put you out of business.
I have no problem with that.
Yeah, I bet you do. I bet you don't. Are there any other, we talked a lot about some of the surgical options, and are there any other non-surgical treatments? I know we talked about, the balloon being non-invasive, but are there any other non-surgical treatments for limb preservation?
So the main thing is whatever medications that you would take to help your heart is good for the rest of the arteries. And so we know that people that take an antiplatelet, so like a baby aspirin, plus statin, so those cholesterol medicines, we know that they are significantly less likely to have heart attack and stroke and to have limb complications. Anybody that has a vascular disease, that has multivessel artery disease, needs to be taking those agents even if their cholesterol is normal, because the statin medicine has like this magical property to it that actually decreases inflammation across all the arteries in the body.
Wow.
And so it's really important that people are on that optimal medical therapy, because that will improve their outcomes in the long run. So that's one aspect.
Okay.
We did talk a little bit, about other ways that we prevent amputation or how we deal with limb preservation. And I will talk a little bit about the other thing that we know significantly improves people's rates of limb preservation, and that's a multidisciplinary limb preservation team.
Okay.
That's on the hospital side of things.
Okay.
But that's the toe and flow team. That is having all these specialists that are involved with limb preservation, because as we said, this is a complicated patient population.
Yeah.
So oftentimes diabetes, they'll have a huge amount of them will have heart disease and other issues going on, and there may be nutritional issues as well, and they have wounds that need to be taken care of. And so having a team where oftentimes the way we describe them in the literature, the way they've been shown to be effective, is you have a foot doctor, podiatrist, and vascular working hand in hand, leading the team, and then we have wound care, we have endocrinology, we have patient navigators. So that's a huge part as well, because a lot of people that end up with this kind of end-stage disease, they're not going to be people that have easy access to healthy, nutritious food and transportation and all the things that we take for granted. A lot of the times we need to help these patients because they are complicated medically and they also need an extra hand. So
it takes a village of healthcare providers.
It does. And so having that village and being able to look at that patient as a whole with the whole team makes a huge difference.
Okay, good to know. So there's been a lot of talk in the news lately about people getting, they're performing too many blood vessel interventions. It's not always necessary, is it?
So that's a great question. Unfortunately, the stuff has come up in the news fairly recently. There was a New York Times article last month, I think, or a couple months ago, and ProPublica has also written about this. And that's about angiograms and stents and things like that being done unnecessarily. And it's a small number of providers, and that's important to point out. It's a small number, but they are doing a huge number of cases. And so it's kind of this crazy imbalance, because there's no way that like there's 5 people in the country that are just like they have all of the people with disease. No, they're probably doing too many procedures. And I think we didn't entirely talk fully about the artery blockages that we see with PAD, but if I just scan people randomly, it's very often people do have PAD and they just don't know it.
Oh, okay.
So if you get screened for PAD, but you don't have symptoms, you should not have an intervention. And it's just really important to understand this. And even if you do have symptoms, we talked about the cramping in the legs.
Yeah.
So that's what we call, the fancy word for it is claudication. And patients that have claudication, again, so they walk a certain amount and they'll have cramping and then they stop and it gets better.
Okay.
They don't have constant pain, they don't have wounds.
Okay.
The only reason that anyone should be offering you an intervention is if you have severe pain that's not going away, or if you have a non-healing wound.
Okay.
People that have claudication should almost never get an intervention. And
so what should they do instead?
So the biggest things, and so we know that this is the gold standard of care. Patients with claudication have to go through an exercise program. Supervised exercise therapy is the gold standard. That is something that's relatively new, and we actually just started a program at WVU last month.
Oh, great.
And that's in our cardiac rehab units. So these physical therapists also have a program for people with claudication.
Okay.
So people with just claudication, the biggest thing they can do is exercise more, to walk more. And what happens when you're walking is your body is sending messages to your legs, especially when they have that pain. It's actually causing a chemical reaction that causes your body to make more blood vessels.
Oh, okay.
Yeah. So the best way to manage this disease is having people walk and keep working on that. It's usually 3 times a week, up to 60 minutes. Okay. And even if, a lot of people have symptoms starting at 5 minutes and they have to work their way up, they will get to a certain walking distance that they can walk pain-free. And we have some medicines we can give them as well to help with that. So the aspirin, the statin, and then we have something that's called Pletol. That's a medication that helps people walk longer without pain.
Okay.
Plus the exercise therapy, plus quitting smoking. All these boxes have to be checked off. And people, if at doing this after about 3 to 6 months, they're still having pain to the point that they cannot do what they need to do, like they can't make it through the grocery store without having to stop. They're totally miserable. That's when we'll discuss doing
intervention.
Yeah, because honestly, the intervention itself, that's not hard. But the problem is that this is a disease that is an end-stage disease of damage to the arteries.
Right.
And so I'll open your arteries, but probably only going to stay open for about 6 months, and then they clog up again. That's just part of the disease.
Yeah.
So as soon as you start intervening, you're starting a ticking clock. And so it's not like the heart. So people that have heart disease, and I'm not an expert on hearts, but I will say that if they see a blockage in your heart artery, they'll go and fix it, right? You can easily live with a big blockage in your leg artery and not know it, because your body can find ways around it and it's not going to kill you. But as soon as you start messing with it, so if I open that up and stent it, and you're still smoking and you're still doing all the stuff, it'll block back up, and sometimes it'll send clots further down and take out the other arteries. And then you're losing your leg because you didn't want to, try an exercise program, or it's not probably not the patient, it's probably that you weren't directed that way, because it's a lot easier for me to do a 45-minute surgery on someone and they go home the same day. So that's where it's really important to understand, and I think patients do come to us like, well, why aren't you doing something about this? There's a blockage here, you should fix it. No, we want to
try everything else first.
Yeah, and oftentimes you don't need it done. If someone has something done for claudication, we know that they are much more likely to end up with a complication later.
Okay. Now, before we run out of time, I wanted to ask you about your NIH grant project that you've been working on to prevent amputations in West Virginia.
Yes, absolutely. And so we'll start by saying that amputation is a marker for health disparities in general. So people, if you show me a hotspot for amputation, I will show you an area that has marginalized population, lower socioeconomic status, has issues getting access to the social determinants of health, so equity, healthcare, quality care, transportation, food security, all of those things. They're all so closely connected. And again, because
Makes
we know,
sense.
it's a preventable thing. And so the patients that, again, people that have disparities in amputations, a place where you have higher rates of amputation, we can find them geographically a lot of the time. And so what we did in West Virginia was we looked at all of the amputations that occurred in the state, and we did compare that rate to the rest of the country, and we do seem to have a significantly higher rate of amputation compared to the rest of the country for people with diabetes and vascular disease. And we identified a hot spot of amputation that's located down in the southern part of the state. And so what we did was we took that information, we brought it to the departments of public health in the area, we brought it to community stakeholders, and we had conversations with the community about why do you think this is happening and what do you think we could do to make it better. And based on those conversations, came together with a grant proposal to the NIH, and that was what got funded. And basically the premise of the grant is to take the things we know help, so making sure providers are doing the diabetic
right
foot
thing.
exams and that they have access to send patients to what they need to, providing multidisciplinary care in a rural environment. So
That's a challenge.
well, absolutely. So we're using the Project Echo platform, which is a telemed platform, and we are providing, so the providers can bring us patients on the telemed platform that they're struggling with, and we have podiatrists, vascular surgeon, wound care, infectious disease, everybody on that call, and then we're able to provide that care in a way without the patient having to come 3.5 hours to see us. So that's the other component. And then we also have a hot foot hotline where if they have an emergency foot, they can directly access our nurses, the providers.
Oh, wow.
And so we've been implementing that in those clinics, but at the same time also building a community level coalition to prevent amputation complications or prevent complications of diabetes. And so we've had this amazing community groundswell of support where they've done incredible projects that included, they worked with the Lions Club to do an eye day. They got funding from Project Pharmacy to get a farmer to get fresh fruits and vegetables to patients with chronic diseases. They have a diabetes support group that's amazing that they have up and running that meets monthly. The community themselves has just done an amazing job. And so all of this is kind of all happening together. And so we're kind of trying to show that empowering the community and the providers in the community, that's where we're going to be able to make a change.
That's the answer.
That's, in my opinion, certainly.
Yeah, yeah.
And so that's what that grant is all about.
Okay. So if people are interested in making an appointment with your limb preservation clinic, what's the best way to do that?
So the best way to get an appointment with my clinic is the 855 WVU care number.
Okay.
And so that's to schedule an appointment, and I am one of the vascular surgeons, and
Okay.
you'd ask to make an appointment with Dr. Minc.
Okay.
And MINC.
Okay. Do they have to have a referral from?
No, you don't.
You can self-refer.
You can self-refer, but obviously if you have a primary care provider or someone referring you, that's even better.
Okay, great. And before we go, I always like to ask, what's the most important thing that you want our viewers to know about limb preservation?
So what I want people to know is that it is an incredibly preventable problem, and it impacts people that tend to be more marginalized. It's unfair the way that it happens, and as a society, we need to do better. We need to take care of our people and bring that equity to everyone, and that's what's going to take care of this problem.
Well, it sounds like that's what you're working on, too.
I am.
All right. Well, thank you so much for sharing this information. I'm sure we've helped a lot of people today. Thank you for all that.
I hope so. Thank you so much.
It was great having you. So that brings us to the end of this edition of Tuesday Talks. If you're looking for more information about treating vascular diseases, visit wvumedicine.org/vascular. I'm Mary Ravazio Menard, and on behalf of Dr. Minc and everyone at WVU Medicine, thanks for joining us.